Hey Chris,
How you
how are
doing?
you? Man, it looks like it's a pretty day out there. I'm in Atlanta. It's kind of cold and rainy. But I wanted to get this Zoom out before the holidays were over because a lot of my doctors are starting a new medical weight loss campaign. And what you do as far as a compounder, I think will add a lot of validity to what they're trying to get done. So, can you tell me a little bit about yourself and the pharmacy that you run
Yeah,
it?
definitely. So, my name's Chris. I'm a PharmD pharmacist. I worked for Walgreens for 5 way too long years until I finally built up the nerve and was angry enough to leave and kind of roll the dice and start my own small independent compounding pharmacy, which I started out in North Austin. That was 14 years ago, and in that time, I've opened 5 others, sold one, sold two. Um, and now I've got three. All of them are in the greater Austin area. And our primary focus is compounding, specifically more on the cash side now. In the pharmacy world, it's changed a lot. When we first started, we were, I would say for the last probably 13 years, we were 98% revenue based off insurance. In the last year, we have switched to being about 98% cash based. So
Hmm.
focus is completely on the compounding side. We do both sterile and non-sterile compounding. And we're just in a new age right now with wellness and peptides and weight loss, where we're in a unique situation to be able to offer uh, a lot of these products that patients would normally have a lot of trouble getting, whether it be because their insurance doesn't cover it and they don't want to spend $1,500 a month. So we've been able to grab a good chunk of market space by just delivering super high quality products of things that are trending, and most importantly, doing it while having a super high level of customer service, which for whatever
Well,
reason is lost upon our industry.
yeah, so you've we've talked, you were in the COVID game. You did the trucks around Austin. You did a bunch of stuff. So you're definitely I consider an entrepreneur and a pharmacist, which is not common. I've talked to a bunch of pharmacists. Most of my clients, I would say, are entrepreneurial chiropractors that own medical centers,
Yep.
and they're niched in cash services, just like you are. So they know how to, like, I have the marketing companies that can crush and
Sure.
get the patients. But you got to be able to sell, put packages together. But part of the problem I'm having right now is the timelines on delivery for products. And then sometimes they don't have them. So I
Sure.
wanted to ask you about, is there really this shortage on stuff, or is it just an investment in your company? Like, how does that work?
So yeah, there's certainly a shortage. Especially, obviously the shortage always stems down from the brands, right? So you've got Novo Nordisk and you've got Eli Lilly. Both of them came out with really solid GLPs. Brands for our Monjaro, which is Eli Lilly's, the generic
Hmm.
or the chemical for that is terzipatide. And then you've got Wegovy and Ozempic, both Novo Nordisk products, and both are semaglutide. And
Uh-huh.
so as soon as the brands fall behind, which they fell behind clearly because this thing just started trending super heavy. I mean, it's the heaviest trending product I've seen ever being in the pharmacy space. And so it's
Oh,
clear why
wow.
they fell behind. And what happens when they fall behind is the FDA has a list called the FDA shortage list. And that's kind of our bread and butter. As soon as an item hits the FDA shortage list, that enables us to legally compound it. And the reality is the brand companies charge what they charge because of research and development. They're the ones that are getting the FDA approval. They're the ones that they're putting tons of money into it. So I don't frown upon their pricing whatsoever.
Yeah.
But the reality is once they've done all of that, these
There's a space for you.
there's a space for us. And the other reality is, when a patient gets semaglutide or tirzepatide from us, it's
Can-
not, oh,
So
you're
on those two products, can you go over the difference between those two and
sure.
how it works in the body? Because I don't think the doctors, although they're doctors, really
Yeah.
understand that there's a difference.
So well, there is and there isn't. They're both GLP-1 receptor agonists. They've both been around a long time for diabetes. Traditionally, they were used for controlling blood sugar, and that was their only indication. And some of the older ones, so not talking about Ozempic, not talking like Trulicity is a good example. Is also a GLP-1, but the difference between semaglutide and tirzepatide is that the half-life is longer than what the older, more traditional GLP-1 half-lives were. And so what that did is basically made the side effect profile a lot better. And then, of course, patients that were on diabetes started using them, and all of a sudden, they've lost 50 pounds, and they're no longer needing blood pressure meds. They're no longer needing cholesterol meds. Um, and from there, Eli Lilly and Novo Nordisk realized, wait a minute, these could be revolutionary for weight loss. And so that's when they sought out FDA approval, which Wegovy was the first semaglutide approved, FDA approved drug, and then tirzepatide was more recently FDA approved specifically for weight loss. So as far as what they do, they affect insulin secretion, they suppress glucagon secretion, they delay gastric emptying, and ultimately they decrease appetite and they reduce body weight. And they
So
do.
on the two products, though, how would a doctor choose, or is it really
So
patient
that's a
tolerant?
good question. Yeah. So semaglutide is solely a GLP-1 receptor agonist, and tirzepatide is a GLP-1 agonist as well as a GIP agonist. So you're getting dual mechanisms of action that are targeting the same type of receptors. So still dealing specifically with insulin and glucagon, again, delaying gastric emptying, all of the same things. But tirzepatide is proven, and there's studies to support that tirzepatide is a superior product. It has
Wow, I didn't
efficacy.
know that, Chris. That's great
It is
information.
definitely superior, but it's also over double the cost. And I'm talking about even at the compounding level. So, you can have for a new patient that's new to these products that's getting on semaglutide, they're looking at it for the first 3 months, $60 a month. With tirzepatide, they're looking at around it's $425 for a 90-day supply. So, 100 and you're basically a little over double what you would be for semaglutide. So the other interesting thing with semaglutide and tirzepatide is semaglutide is an amazing product. My father-in-law lost nearly 100 pounds using semaglutide. But what happens with every single patient is they will eventually get to the point where they plateau and it just doesn't work anymore.
I
Now, for
see.
some people, that may be a year. For some people, that may be 3 months. For some people, that may be 2 years. There's no way to know until it's very patient specific. But what's awesome about tirzepatide is now what physicians are doing and what we're seeing clinically is working amazing is start the patient on semaglutide, let them hit their plateau, and then switch them to tirzepatide. And all of a sudden, boom, it's like they get a second round that otherwise, if we didn't have that product, that they would kind of be tapped out. Um,
Gotcha.
so that's what my recommendation has always been to our providers is, hey, start them on semaglutide, see what results they get. And once they're at a point where they're not getting the results they want, then you can make the switch.
So, so what about patients that have done very well since it really is, you know, handling A1C, blood glucose, gastric. I would think that the patients, if they're doing well with it, would stay on it. Is there a harm for staying on this type of a product, or what? And just me to you, not like,
Yeah, so no, so again, all of this is it's very lab based, right? So like any other med, the most amazing thing about GLP-1s is the fact that, and as a pharmacist, I see this you know, it boggles my mind to have a patient that has to be on 9 different meds, right? One to control this, one to control that. So the most amazing thing I've seen with GLP-1s is that you're now, not only are you giving the patient the ability to lose weight that actually works, but I've seen patients that no longer need metformin, no longer need their beta blocker, no longer
And
need
that's awesome.
metformin.
That's just
It's
awesome.
amazing to go from being on all these different meds to now just having to be on this injection, is an amazing thing. And so I wouldn't necessarily say I see patients getting off of them. There certainly are patients that end up getting off of them, but what more so we see is these drugs are always titrated. So you're going to
Hmm.
start at a really low dose. You're going to get to a much higher dose. And then when you've reached your goals and your levels are where they need to be, you've lost the weight you want to lose, you're going to titrate down and then find a lower maintenance dose so that you don't need to go back to your metformin or your blood pressure meds. But again, this is so patient specific. So
Yeah. So, but you know, I've watched that, and the only um that's why I like to talk to pharmacists, because the the truth is a farm rep doesn't know what they just have a trifold brochure and
sure.
so the truth is, let's say that I'm at um you know, zero point 0.5 cc's and I've lost all my weight. I could expect on a maintenance to be somewhere between zero point 0.2 to zero point 0.3 and still maintain what I'm trying to do. I've had some people that got all the way to 1 cc in treatment, and I go, you know, there's no way on a maintenance level that they can afford to keep
Sure.
that up.
Yep.
So knowing what you just told me about trizipatide, that makes a lot of sense, man.
Yeah,
It'll the game changer.
and you see it, I mean, especially, and that's obviously going to be more applicable when you're dealing with someone like my father-in-law who he needed to lose 130 pounds. Um, I mean, we've got patients that are, barely, their BMI is barely over, and they're like, well, I want to lose 10 pounds. Um, that's a much different scenario than a patient that comes in that's morbidly obese. And
Gotcha.
so, clinically, as far as their dosing, as far as how long they're on it, the titration, all of that should be customized to that patient. And obviously there's guidelines, right, that say, well, you're going to do this for 4 weeks, and then you're going to do this for 4 weeks, and then you're going to do this for 4 weeks. But the best clinicians out there are not just going by a guideline, they're going by their patient's actual change, because again, it's so variable. Some patients are super sensitive, others they start and they're on 50 units when
Yeah.
and it's working a week into it. Other patients take 8 units and they're vomiting everywhere and they don't eat for 10 days.
Yeah. So the doctors that want to do this, I'll just let them know what I did. One, you know, I put together packages uh that I think are very easy to sell. We have patient financing, and I also uh grabbed a chronic care management, remote patient monitoring management company that's insurance based, and Legoed it together for this thing. And so literally we ship a digital scale that's 4G, and we're having a record of that weight every day. So I have a graph. Um, I have when they don't get on the scale, and then this company does a phone call to interview. So the work of weight loss is after you sell, where people screw up is they don't want to talk to that person anymore.
Right.
Um,
Right.
but but I found a company that'll do that for like $50 a month. So there's no way that you shouldn't add that into the package and let them do it. What about muscle? Because I've heard this and I've seen this too. Is there any side effect to mixing like a cypionate or a testosterone product with these products, or one of the, I guess one of the peptides that
Sure. No,
you need?
there's again, especially when we're talking about peptides, there's obviously limited history, limited research on really, I would say 90% of them. With that said, I'm a huge peptide guy. I think that peptides are revolutionary. I think that they're way better than, if you've got a guy that no matter what, he's got his mindset that he's going to increase his HGH, and he goes out on the black market and buys HGH injections. For him to be able to come to me or a clinician and us work together with him to say, hey, no, you're going to use, tesamorelin or CJC 1295, and we're going to do it in a natural way. I think peptides will be the future of medicine. I strongly believe that, but the reality is they haven't been around forever. Now, with that said, which means we have less data for long-term, interactions, long-term side effects, et cetera, et cetera. Bottom line is the longer they're around, the more we're going to know. With that said, I've seen miraculous things, especially when it comes to things like building muscle mass and anti-aging. I've seen some really, really incredible things. So the other thing is, again, a lot of patients are on multiple peptides. Most of them are, because if they're going to a clinician that understands peptides, typically clinicians are seeing results that they haven't seen with other typical big pharma products. And so they start diving more and more into the rabbit hole, and they start using more and more different peptide options. And so I haven't seen, and we do a lot of them, I haven't seen any patients have any crazy interactions where they're on semaglutide and testosterone and there's been an issue. But again, I think, anyone that's on TRT needs to be getting their, blood levels checked regularly, and you monitor markers and you take it from there. But no, there are I guess to answer your question simply, there are no just outright drug interactions that you need to worry about when you're mixing peptides.
Well, there are some compound pharmacists, as you and I talked about, the FDA is watching a lot of these different products, and their watch is based on what big pharma says to watch. Let's be honest.
Yeah.
So some of the compound pharmacists, when they get a letter in the mail from the FDA, they go, you know what, I don't want any problems. I'm just going to close this. You've invested very heavily in this end, not only with products and services. You told me about how you guys make your product, how fast you deliver, but also on the legal side of handling and answering those questions from the FDA. I talked to probably 3 pharmacists in the past month, and 2 of them just stopped doing peptides altogether just because of a letter.
Yep.
What makes you confident to, not that you're not going to change the FDA, but what makes you confident to stay in this game?
That's a good question. So first of all, let's talk about the letter that went out, right? Because I think a lot of, and that went out not to just pharmacists, but to clinicians, MDs across the nation, right? So,
Yeah.
And I don't think a lot of them understand what the letter actually meant.
No, they don't. They just see a letter and it says FDA in the left
Right.
hand
It's
corner,
scary.
and then they go, I'm done.
Yeah. Yeah. So what that letter actually meant was, the FDA has 3 categories for bulk APIs, bulk powders that we're able to legally compound. They can move they can move peptides, they can move drugs, pharmaceuticals. The FDA can say, oh shit, we just noticed this crazy adverse effect, so we're going to move it to a different category. So what happened with that letter that went out is the FDA basically said, we're going to move this whole list of peptides, and it was a lot of the best ones, and we're going to change them from being a category 1, which is like, have at it, compound them, and we're going to make them a category 2. And now what a category 2 means is the FDA feels they have reason to believe that they're going to do their own trials or extended research, because they believe there may be a safety risk or an increase of adverse effects with certain items. And so if you're going to compound them, they need to be compounded with extra precaution.
Gotcha.
Now there's also a category 3. HCG is now a category 3.
So it's done. It's got
done.
a red mark on it.
You can't touch that. If you do, you're breaking the law.
It's regenerative medicine now. It's considered.
Yeah, well, now it's a biologic. So unless you have a biologics license, you cannot, as a compounding pharmacy, which you will not attain because that's a manufacturer level, you can't make HCG. So now the difference between that and a category 2 is, let's say the FDA comes in and does an inspection or comes and audits you, which they can do at any given time to any pharmacy. Now,
Well,
when they
Chris,
come in,
the heat is not on my doctors.
it's not, it's on the
It's on
pharmacist,
you.
on us. And what happens when they come in is if it's a category two, they will look at your records and they can, at that point, make a decision and they can say, Chris, we don't want you to compound CJC anymore because it's a category two and we're still doing more research on it. So we know it's a category two, but stop doing it until we figure out what we're going to move it. Okay. So now at that point, I'm going to stop compounding that product. What they come in, it's not like it wouldn't be the same as me compounding HCG and they come in. They would say, what are you doing? This is a red strike. You get to get a board order. You're going to get, at that point, you are getting slapped on the wrist. So there's a big difference between a category two and a category three. The next big question I get is, well, when is it going to become a category three, or is it going to become a category three?
And the answer is you don't
Thoughts
know.
on that are, I don't know, but I don't
Of
think it's
course
going
you
to
don't.
be soon. I mean, I think we've got a year, maybe 2 years. They're slow to
Yeah.
move. And the other funny thing is the only ones that weren't on that list were ones that are that there is a big pharma drug company that has trials in progress to make them FDA approved. So mind you, the only ones that they put on that list were the ones that big pharma is not already involved with. So what big
Yeah.
pharma wants is to have their hands in it
Right.
before and eliminate us. The reality is because
Irony.
we're cheaper.
The irony is hypocrisy. It's just
Right.
crazy.
100%.
But my doctors have been through this before. So I just want to go over as far as uh, you have semaglutide, trizepatide, you have testosterone, you have peptides. Um, one of the major things that you said, Steve, I'm competitive in pricing. The truth is, although you said that your prices are fine, man. They're below the other companies, the big companies that I'm dealing with. So I just want you to know that your pricing is totally fine. It's it's the speed of your delivery which really makes a big difference. So you guys get products out in about a week. Most other pharmacies, 2 weeks
Two
plus.
to 3 weeks, 4 weeks sometimes.
Yeah,
And a
and that
week for us is long. 72 hours is our rule. Our staff knows if a script comes in, get that thing out within 72 hours to the patient's hand.
and I just think that part's awesome. The other part is you're willing to have the FDA come in and do that. You're prepared legally. You're not afraid of that. You understand that that's part of playing the game, and that's because you played other games that were in
Sure.
that area.
The industry we're in, right?
So the other part that I've had in some very big, well-known national firms have told me before, just like we're doing the Zooms, like, hey, Steve, don't send any more information out. We're just gonna pause right now. And I'm like, I have guys that have been selling products and have patients on these
Right.
products for over 2 years. You can't just pause.
Pull it. Right.
So we're
And what do
treating
you think they're
patients.
doing? Scrambling now, and they're buying them on Instagram for research only, for animal use only. That's how, because you can buy any peptide online. Just Google anyone, even semaglutide. It is not the same as a legitimate FDA sourced powder from a legitimate compounding pharmacy where the powder itself has a master drug file, which is basically something they get through the FDA, where the FDA comes in, inspects the powder and says, yes, this is legitimate and it is 100% identical to what Novo Nordisk uses or what Eli Lilly uses. They've been
Yeah,
FDA registered and they're FDA inspected. Big difference between anyone can get FDA registration, but has the FDA come in and actually inspected them? Those are the things that cause our costs to go up.
yeah,
I could spend $400 on a gram of semaglutide, but I choose to spend 4,000. That's not because I want to spend $4,000 per gram. It's
right.
because that manufacturer has checks and balances that make me know what we're doing is as legitimate as you could possibly do it.
So you don't order off of Alibaba.
No. No, sir.
I got it. Well, Chris, is there anything else you want to share with the doctors? Because I'm going to send this out. It should hit right in January, and a lot of the doctors are going to want to. First off, what states are you currently working in, and how long does
Yeah.
it take to get a doctor or you to get into that state? So what states are you currently working in?
So our current licensures are in obviously Texas. We've got Louisiana, Missouri, Florida, uh, Kansas, Colorado. Um, New York just is getting released. They approved it. I'm just waiting on New York certificate. And then we've got about 25 other states in pending
Pending.
status.
Gotcha.
And so usually what I'll do is just update. I already have a few states with clinics that are waiting, and so as soon as those states push through, I'll update those providers. But I'll
Gotcha.
keep you in the loop on that as well,
Okay.
because it's a constant thing as they roll in, and the reality is that you never know when they're going to roll in.
Yeah.
But Kansas, I don't know if I said Kansas. We're also in
Yeah, you
Kansas.
did.
And then Tennessee as well has been released. We're just waiting on the certificates to come in. So
And I have a ton of
learn
guys in
pretty
Tennessee.
quickly. As far as onboarding goes, it's super simple. We'll send them an email that has everything in one email, the pricing, how everything works. The other big thing for me is being able to connect with what I love about this part of the job is being able to connect with the providers directly, especially initially, to answer any questions they might have directly. As well as explain kind of the overall process to them or work with their office manager, so they know exactly what to expect. And then other than that, I would say that I think we really hit all of
Yeah. No,
the
that's it.
things on the
And
head.
for me, I will help the doctors with marketing, patient funding, and I have some PowerPoints that make patient education really, really simple. So it's not really a sale, it's education. And we're doing this on a virtual platform. The RPM group that I use is called Kangaroo. That's been way better than expected. You do a Zoom and it's a sale, but
Sure.
they have followed up. I've looked at the notes in our patient files, and man, it's unbelievable the way that they monitor the patients, make recommendations, and your nurse could literally just look at one dashboard and see all of the patients and see what the notes are, and it just makes it turnkey.
Well, the other good news too, the last thing I'll say before we disconnect is, this blew up for us probably about 6 months ago. When we started it, the first month, and I've got a team of reps we don't do any online marketing is another big thing for us. We don't, the last thing we're trying to do is put ourselves out there to the entire world. Our marketing is very internal, very organic, straight to the physician.
Yeah.
But when we started, we started the program about 6 months ago. And we went from what was 2 clinics to, I would say by the first week of January, we'll break 1,000 in-house clinics that are utilizing our products.
Oh, wow.
So there's what I would encourage your physicians to think about is there's there's so much demand for this, and there's not enough that we don't have enough clinicians out there right now that are doing it. So this is like if you jump in, you're going to have success. There's no doubt about it, especially if you're doing it the right way. So
Yeah.
commend you on what you're doing, and I look forward to working with you and any of your physicians in the future.
Yeah. Well, thanks, Chris. And like I said, I think I'm going to be there mid January to work with Westlake Hospital, and
Okay.
we'll have some dinner. We'll have
Definitely. I'll be
some
looking
steak
forward to
or
that.
whatever.
Yeah, we'll have to bring Dr. Festi in as well.
Yeah, that would be awesome. All right, man. Thank you very much. I
I appreciate
appreciate
it,
it.
man. Have a good day.
Yep. Bye bye.
Thank you. Bye-bye.